Welcome again to yet another episode of the Nailed It Ortho podcast. I am one of the hosts. I'm Dr. Cole, and I'm joined here by my other co-host.
Hey guys, Dr. J Fitz back with you guys.
Sometimes it's also referred to as my little brother, but right now, we're doing the co-host thing. We have a pretty good episode for you all today. We're kind of going back and forth. We kind of have a sports topic for you all today. I'm actually going to let Dr. Fitz let y'all a little bit more about our guest for today.
Absolutely, man. And just to add in, I have to let him do that because I'm really like the sparkle in this guy's life. So, I just got to let him make those little jokes and make him feel good. No big deal. But this is another guest, guys. I'm really happy to introduce this gentleman as well. I think this might have been the second time I wrote a paper while I was in medical school. This doctor, this gentleman, he gave me the opportunity to be on the paper with him. So I really appreciate it. His name is Dr. Okorha. He did his residency at the Henry Ford Hospital in Michigan and his fellowship at Rush University in sports medicine. And he came in talking about something that's, I hear different things about it in the sports field and the hip field and things like that, hip labor repairs. Some people do it, some people don't, but I think he did a great discussion on it, just kind of giving us an overall view of things. So with no further ado, I think we're just going to jump right into this, and I hope you guys enjoy.
You are now listening to Nailed It, the Orthopedic Surgery podcast, featuring Doctors Jay Fitz and Wendell Cole.
KC, thank you so much for coming on the show. Welcome to the show, first of all. Welcome to the Nailed It Ortho podcast. I want to call you Dr. KC. I know you told me to call you KC. That's your nickname, so I'll say Dr. KC for now, man. But
no problem, man. Happy to be here.
Yeah, we're happy to have you. We're happy to speak with you and talk on a topic today. We're talk about some hip labral tears. Interested in the subject. I don't know too much about it, but I think this will be a good talk to get people tuned to the fact there are hip labral tears and kind of how to manage and go about managing these patients. So Thanks again for coming on.
No problem.
So we typically like to start out with just a couple of questions, getting to know you, and we'll start with the age-old question that we all get asked in our interviews sometimes. So what made you choose the field of orthopedics surgery? I guess in particular, what made you want to go into sports?
So it's a couple fold. Naturally, I played basketball my whole life. Growing up, I thought I was going to play in the NBA. So basketball has been my whole life. So first in med school, when we I think it was like in the first year, second year, we started dissecting cadavers. And then I really realized that, I wanted to be a surgeon. And then kind of choosing in between the fields, I was interested in neurosurgery and orthopedics. I kind of stumbled into orthopedics. And then I found out, you can manage athletes and, athletic surgery. So, and then I kind of just blended right in with what I wanted to do. So orthopedic medicine, sports medicine is the field I chose.
Okay. And on that same topic, because I happen to know, like you said, that you played basketball in the past. Do you see, I guess, is there any lessons that you learned during your time playing basketball that you see still is helpful now for you in your practice?
I think the main thing that I, take from basketball is the work ethic, and commitment. When I play basketball, I was always a gym rat. I'm always, first in the gym, last in the gym, Saturdays, 24 hours a day, if I could be. So I think with being a surgeon, it's about learning. You got to know the anatomy. You got to know how to do the surgery, but it's also about practice. So, whenever you're able to get in that lab and practice on, cadavers or whatever you may be able to practice with, that makes you a better surgeon. So I think that's what I took from basketball.
Absolutely. And I'm just curious, were you a 2 or a 3? Or you might have even been a 4 at the time?
It's 2-3 guard.
2-3 guard. Okay. All right.
Yeah,
Sounds
yeah. A little slasher, you know, a little razzle dazzle.
I like it. And continuing on that note, another question I have is this is, I guess, more of a retrospective question, but you know, if you were to look back at it, at yourself and kind of where you're at when you first started residency, or let's say when you're 25 years old, I'll say that. Do you have any advice that you would give to your 25-year-old self, having kind of gone through what you've gone through, you know, in the past couple of years? And
25-year-old. So I was in medical school. Yeah, I think I was in medical school at that time. Medical school was a little different. I went to Howard in DC, so great school, but it's a kind of an atmosphere where, you know, it's kind of a party atmosphere. You know, you can get distracted very easily. A lot of parties, a lot of women. So I think I would tell my younger self to focus.
Yeah.
Because the thing about medical school is you don't think about it, but there's class ranks. There's a lot of like things that go into that, AOA, scholarships, and that your rank pretty much gets set pretty early. It's hard to change after that first year and a half. So if you get behind, then you got a steep hill trying to climb up, especially if you want to do orthopedics, because, you know, they put high value in your test scores, your class rank. And so that's probably my biggest advice to myself would be.
Anything when you first started residency that you would go back and tell yourself?
From residency, no, I don't think I would change much about my residency. I think my residency went pretty well. Again, you could always focus, you could always do more, but I think I did pretty well in residency.
All right. Well, sound good. I think we can go ahead and bring up the case for the day. And this one's a little bit vague, but I feel like this may be how the patient would actually present. I haven't seen it personally, but so we're going to give it a go and go from there. So we say we have a 19-year-old male, but we can say he's a basketball athlete who comes in with a 7-day history of hip pain. And he states that he feels like a snapping sensation sometimes when he walks, and it seems like it's a little bit worse after he practice. He say he can't really remember a specific incident when this first started, but he said he noticed it one day after basketball practice. And he's coming in now with this hip pain. And I guess from here, where will we go as far as, I guess we can either go from, if we're looking at the labrum, we can go from either the H&P at this point, or we can talk about anatomy. It is kind of whichever way you would like to take it at this point.
I mean, I think it's important to talk about the anatomy first, because you kind of get a couple of different things that it can present with. So the hip is obviously it's a ball and socket joint formed by the articulation of your femur and your acetabulum. So a couple of different structures that kind of compose the hip. You have the cartilage of the hip, which is kind of the lining on the bones, and that kind of lets the bones move in that congruent, smooth, free articulation. You also have the labrum, which is a horseshoe-shaped fibrocartilage that attaches to the outside of the socket. And that essentially deepens the socket and kind of provides some stability in it. And inside the labrum, you have proprioceptive fibers and nerve fibers. And when that labrum is injured, those proprioceptive and nerve fibers kind of send different signals to the brain in the form of pain to let it know that, you know, this action is causing your body harm. And then the capsule forms around the femur and the acetabulum. And the thickening of the capsule is called ligaments. And those are also form the structure of the hip and allow the socket to move, providing hip motion. So those are some of the basic structures in the hip that can be responsible for pain on the intra-articular side. So in this patient, you said 19-year-old basketball player, 7 days of acute onset. I would ask him, what was he doing when the injury happened?
He just says pretty much he's not 100% sure, but he kind of noticed it after he was done with basketball practice that day.
And no history of any hip pain in the past?
He said before then he might have had some pain from time to time, but is definitely worse now. He's noticing it a whole lot more. And it's getting to the point where.
What kind of actions make it worse?
Well, he says he notices it when he's when he runs, when he's doing his sprints during his practice, and also sometimes when he's doing some of his stretches before and after his workouts.
Right. I mean, so the young athletic population, there's a couple of different differential diagnosis you can think about. So a lot of patients that have high impact activities, high flexion activities, basketball players, football, dancers, have what we call femoral acetabular impingement. And that can come with multiple components. You can have a cam deformity, which is extra bone on the end of the femur. You can have a pincer deformity, which is extra bone on the acetabulum. And when those bones contact each other, that can impinge on the labrum, and then you can get a labral tear. You can get subluxation of the joint, causing injury to the cartilage. So there's a lot of different factors that can go on into that. In a person with only 7 days of hip pain, you might try to treat that conservatively at first. So, hey, you might have, a hip sprain or a contusion. Let's see how you do. Maybe shut you down for a couple of days, do some therapy, and then reassess them.
Let's say, they first come in to the office. What are some of the things that we're looking at, on the physical exam? Are there any tests that we want to do, or, things like how should we look at that? And what are like some of the physical exam findings that'll clue us into, hey, this is something that may be of, of hip, of the pathology, of the labrum.
Right. So first thing you're going to ask them to do is point to where the pain is at. So people with a labral tear, FAI, they do what's called the C sign. They put their hand right over their hip and say, this is where it hurts, or they point in their groin. So groin pain is more specific to labral tears and FAI syndrome. And then you're going to kind of take them through a range of motion. Patients with labral tears have pain in flexion, adduction, and internal rotation. That's the major provocative examination for labral tear. Also, you can flex them all the way up. They might have pain with terminal flexion. Those are the big exam findings.
Now, you said the pain with the flexion and adduction and I believe internal rotation. Now, does that tell you that they have a labral tear at any specific location within that labrum, or does it just tell you kind of in general, this person might just have a labral tear?
Yeah, I mean, and it might be a labral tear. It just lets you know you have some impingement in the joint.
Right.
It doesn't necessarily mean you have a labral tear or you just have bony impingement, but something's going on in that hip that's causing them to have that loss of internal rotation and flexion.
So once we get this patient, they come in and they tell us this history, and we do that physical exam. We do that provocative maneuver, which elicits pain right in his groin region. Where do we go from there? Would we getting imaging, or what would be the kind of the next steps in evaluating this patient?
Yeah, so most patients, if you show up, for an orthopedic, you're going to get at least one image. X-ray is something pretty safe, doesn't cause a lot of morbidity from one X-ray. So I would just get a plain X-ray and see what that shows. There's a couple different views you can get, what you're done, your lateral, your AP, and that will show you a bony deformity if you have one, or maybe a bony defect.
Okay. Yeah, that was going to be my next question. So that's kind of what you're looking for in this particular type of case, trying to see if there is any bony defects.
Yeah, or if you see extra bone on the end of the femur or the acetabulum. So if I see a huge cam deformity, which is the extra bone on the femur, or pincer deformity, then you know that somebody has FAI.
And for those listening that may not know, what a cam or pincer deformity is, what is that?
Yeah. So basically, when you have that deep flexion and internal rotation, the end of your femoral head abuts on your acetabulum. And so one of the body's main laws is Wolff's law. So once a stress is put on the bone reacts to that stress to try to protect itself. So if your bone keeps on impinging on your other bone, causing stress to your bone, the bone on the femur will form more bone to protect itself. But by doing that, it decreases the rotation before the femur and acetabulum abut each other. So basically you have limited motion then, and your femur abuts your acetabulum even sooner, and that process kind of continues.
Right. So say we get our films and we see that they have a cam lesion, do we just stop at x-rays or do we get continued imaging? Say this person, we got that and we got the x-rays that showed those lesions, and, we tried, non-operative treatment, which we'll talk about in a bit, but that doesn't work and they come back and they're still having pain. Do we proceed with further imaging, or kind of how do we go about that?
Yeah. So in that patient, we continue to pay a young patient, I would get the MRI because you want to take a look at the soft tissues. You want to see if they have any cartilage defects. You want to see if they have a labral tear, because those are modifiable things that you can actually treat and try to get this patient better.
Okay, and along with that, of course, is there any good use for, I guess it's called the MRA for this type of injury?
Yeah, so MRA is an MR arthrogram. So that basically what that is you're putting fluid in the joint, and that helps you attenuate labral tears and cartilage defects, because your fluid kind of gives you that contrast, and wherever that goes, there's an injury there. So that is actually better in identifying labral tears and cartilage defects, but most of the time we can see it without using the contrast, because sometimes that can have some morbidity involved with that as well.
Okay.
What I will get an MRA for is a revision patient. Somebody who's already had a couple surgeries, because then it's harder to tell what's normal and abnormal anatomy. So that's when I would get an MRA.
Yeah, and is that your main? I was going to ask that. So that's your main indication in order to get an MRA? Is that patient, or are there any other indications where you say, hey, I think an MRA may be warranted in this patient?
I think it also has to do with the image quality. So if you don't have a high Tesla MRI, maybe you're at a under populated hospital and they have low powered MRIs, you might want to get an MRI just to get that better detail. But most of the MRIs we have nowadays, you can identify labral tear or cartilage defect without contrast.
And so also when we're looking at these images, what exactly are we looking for that's going to clue us in that there may be an injury to the labrum?
Yeah. So the labrum is a nice black triangle that's on the end of the acetabulum. So if you have a linear line, with the contrast is white on T2 MRI. So if you have a linear line through that black triangle, and then that identifies a labral tear.
Okay. And so say we do that, we get an MRI and, our suspicion for a labral tear in the hip is confirmed. How do we go about treatment? Like, what's the algorithm, between non-operative versus operative treatment? And then what are the non-operative treatments? And then what are the operative treatments?
Right. So you want to know what's that patient tried. If it's a young patient, it's been going on for 6 months, they tried physical therapy. Those are the kind of patients that you lean more towards surgery in. What you can do as another step to kind of identify, hey, this is specifically coming from the hip, because a lot of things can present as hip pain. As you guys know, the nerves, come from the lumbar plexus and spine, glutes, SI. Those can all be, even knee can all be referred to the hip. So if you really want to identify as coming from the hip, you can do an injection. So we do a corticosteroid and Marcaine injection in the hip, and it does two things. One is diagnostic. It tells us if they get better from that injection, then hey, this is coming from the joint, somewhere in the joint. And then for some patients, it's therapeutic. So they might get 2 months relief, 6 months relief. And in those patients, usually those are the older patients, you might be able to let them continue with non-operative management. But usually in the younger patients, if they have a labral tear, they tried therapy, that injection might give them some relief. But when they try to go back to that high impact activity, they'll start to have pain again. And then that's when it's time to have surgery.
Now, a question I have regarding physical therapy now, I guess being an intern and writing orders for physical therapy and being specific, working on range of motion versus strengthening. Now, for these patients, are they going to, like, what's the physical therapy order, or what's the goal of it? Is it to increase their hip flexion strength, or is it to increase their flexibility? Like, what are your kind of, like, what are the specific goals of this, non-operative treatment of physical therapy?
Yeah. So what happens is when you have that labral tear, you have a lot of inflammation in the joint, and your motion kind of gets offset. So what you have is you have compensatory patterns. Your glutes are off, your core is not stable, you walk differently, you don't have that hip extension because that causes pain, and that throws the rest of your body off. So what therapy specifically can do is can fix those other patterns that fix your neuromotor control, your core stability, your glute strength, and that might reduce the pain for that patient. Also, what physical therapy can do is teach the patient on modifiable factors. So supportive shock absorbing shoe wear during exercise and work, low impact exercises. Somebody might run all the time, but if you have a labral tear, once a week is fine, but every day that's going to cause you more pain. So you can still exercise, but low impact. So biking, swimming, elliptical, and then balance exercises and improving the lower extremity proprioception is big.
Once we have our patient go the non-operative route, they're trying the physical therapy and they're back, and they're saying that, hey, this pain's not going away. What are the surgical techniques for this type of injury, and kind of what is the goal?
Yeah, so a basic goal for surgery would be to eliminate the pain and get the patient back to the activities they were doing previously. Kind of the process is called hip arthroscopy. So we do it usually through 3 small incisions the size of your fingertip. There's an anterior portal, there's a mid-anterior portal, and a dala portal, which is more distal. And these are all on the front of the hip. And then through that, we can stick a camera in the joint. We do a detailed examination to find any pathology. Any labral tears we find, we sew it back together with sutures. Any prominent bone that we talked about, either the cam deformity, which is the excess bone on the femur, or the pincer deformity, the excess bone on the acetabulum, we shave back down to normal. And then we do all this through an incision in the capsule. It's called a capsulotomy. To open the hip, we close that down, called a capsular application at the end of the procedure.
Now, how are the results of this type of procedure? How is patient satisfaction? What's the recovery like? And I guess that's pretty much my question. Like, what's the patient satisfaction level, and what's the recovery time looking like for these patients?
Yeah, so we have a lot of great studies out on patient satisfaction. It's actually really good after the surgery. What patients need to know before surgery is that it's a really intense rehab process. So it's like an ACL, but it's a pretty intense physical therapy process, about 6 months to get back to doing the sports.
Okay. And so another question I have is, because, I know that you're, one of the team doctors for the Chicago Bulls and the White Sox. Now, in the high level athlete that you suspect that they have a confirmed hip labral tear, are the management options still the same, or would you go straight to scoping the hip to try to get them to return to play the quickest, or does it change the way you kind of manage that patient in the high performing athlete? This is their career. Athletic performance is their career.
Yeah. So professional athletes are a whole nother ball game, because there's so many different factors that influences these players, contracts, time of the season, playoffs, when they want to return, coaches. There's a lot of different factors with professional athletes. So I'd say the difference is most of the times you're just going to get imaging with a professional athlete. They're going to get the X-ray, MRI off the top to see what's going on. And then surgery, I think it's the same. If you feel like the patient has a labral tear, they're young, they're probably not going to get, physical therapy, like we said, can fix those modifiable factors. but they're not going to fix that's not going to fix the labral tear. It's not going to fix the X6 bone. And so they're going to need surgery.
Okay. And also, just like when we were looking this up, it seemed like this is kind of a new, somewhat like a new diagnosis in orthopedics. Like it's something that's kind of new and people are looking like more into it at this point. At one point, it wasn't something that people kind of considered for hip pain. So my question is, how is everybody kind of on board when it comes to managing these injuries operatively, or do you see that some people do it and some people say not so much, or kind of what's your thoughts on that?
So I think the thing is, if it's been around, so it didn't hip FAI and hip pain and labral tears didn't just start. It's just we weren't treating it before. So 30, 40 years ago, nobody knew how to do a hip scope. Nobody knew how to fix it arthroscopically. So what you would find is a large portion of athletes or high contact people have FAI. Some are asymptomatic, some are symptomatic. Just like if you get an MRI and a lot of people over the age of 40, they'll have asymptomatic rotator cuff tears. But it's the patients that are symptomatic that we then need to treat, because we can change their course. We can make it so that they're able to play these sports without pain. Whereas before, they might, stop playing because they just have pain all the time.
Okay. I was pretty curious about that, just because when I was looking up the articles, I was kind of getting, seeing different things, and I can tell it was something, like you say, a couple years ago, or a couple decades ago, it wasn't something that was being managed. So that's good to know. And overall, I learned quite a bit on this topic. I think it was very helpful, because coming into it, I was very, very light, and so this gives me something to work with to kind of learn and go forth for sure.
Right. It's all about learning.
Absolutely.
50 years ago, people were just, starting to talk about hip replacements, knee replacements. I think, once we advance with medicine, we find ways to, treat these things that before we just lived with. You got old, you couldn't walk, and that's what it was in the old days. But now we have ways to, normalize what the abnormalities with hip arthritis and labral tears, and these are all things we can use to benefit from in the future.
Absolutely. And actually, before we wrap it up, last kind of question I have with this, are there any complications that you tend to have to look out for after, we could say after surgery, or sometimes even if they go the non-operative route? Is there something that could worsen or anything like that?
So the normal complications with surgery, infections, bleeding, things like that, nerve damage. There are some small nerves that go around the front of the hip. So some patients, you can have some numbness or even a neuroma, but those are very small. I'd say less than 5%.
All right. Absolutely. Awesome. So before we go, Dr. Casey, we always like to give our speakers a chance to give all of our listeners a way to reach out to them, or how to contact them if they want to. And I happen to know that you have a presence on Instagram, so I was going to see if you wanted to give that while you're with us.
Yeah, no problem. You can check me out at Dr. Okoro, Okoro. That's on all social media platforms: Instagram, Snapchat, YouTube, the whole 9 yards.
Absolutely. Well, there you go. I hope all the listeners enjoyed this talk. I know I learned a whole lot. I see Dr. Cole over there. He's still writing down his notes. So, hey, we're doing good over here. All right. So, again, Dr. Okoro, I want to thank you for coming on to the show. And I want to thank all the listeners for absolutely.
Yeah,
all right.
I really appreciate it.
Now, thank you all for listening to that episode of the Nailed It Ortho podcast. We talked all about hip labral tears with Dr. Okoro. I hope you all enjoyed it a lot. If you did, please go ahead and hit that subscribe button. Subscribe to the podcast. Go ahead and subscribe to us on our platforms at nailedortho.com, as well as on Instagram at nailedortho.com. Just kidding. It's just Nailed It Ortho. All right. Until next time.